Welcome to the Ophthalmology webinar for eye concerns in genetic aortic disorders.
This event is being hosted by GADA Canada, and I'm Chrisanne Campos, the Executive Director, hosting this event for GADA today. And with me today is Joe Pasca, the President of GADA's Board of Directors, who will be moderating this event today. We are absolutely thrilled to be hosting this webinar, which is the second in GADA's webinar series this year. The first one was focused on exercise or fitness for those living with a genetic aortic disorder using Pilates. This webinar is being recorded, and the recording will be available on GADA's YouTube channel, where you will also find the recording of the exercise webinar and other videos of the organization. So please visit GADA's YouTube channel when you have a chance to learn more. Before we go ahead with the webinar today, I'd like to take a moment to go through the disclaimer for this webinar. Please note that the contents of this webinar, including the presentations and discussions presented by GADA Canada or anyone else presenting in the event, is only for educational and informational purposes. None of this information should be taken without consultation with your healthcare professional. Genetic aortic disorders are complex disorders, and they need a skilled and trained healthcare professional to be managed. None of this information, medication, or courses of treatment or lifestyle recommendations made through this webinar should be undertaken without being discussed with your physician. So without further ado, I hand over this webinar to Joe Pasca, who will take over and moderate it from here on.
Hello, everyone. It's really nice to have you all join us this evening. I will just take a minute to give you a bit of information about GADA, Genetic Aortic Disorders Association in Canada. As some of you may not know about us in so many details, we are really a typical volunteer-based and non-profit organization with major concerns in genetic aortic disorders. They started as Canadian Marfan Associations in 1986. I have personally been involved with it as volunteer since 1990. And 20 years ago, with a technological developments that allowed a finer research and generate finer information from the various research, we have found out that there is a whole slew of new mutations that are causative of aortic aneurysm and dissection. Some of them, like Marfan Syndrome, have a very pronounced involvement of the eye, particularly some of the lowest D's forms. However, most of the other, if not all of the other genetic aortic disorders really we just don't know much about. So we have focused as an organization on absolute well-being of the patient, and that means that that we educate, we promote awareness, and we promote research through creation of clinics, aortic clinics. We influence them. We don't create them ourselves, but we influence their creation by bringing the specialists together with the institutions. We have about 12 such clinics across the country. But in order to treat the patients at the clinic properly, and that not only Marfan patients, but everyone else, we are desperate for new knowledge and an understanding of new diseases that did not have a privilege of 40 years of research that we have seen with Marfan. So GADA has organized an international consortium called Multi-China Aortic Consortium that we popularly call MAC, that consists of 66 centers across the world and encompasses the researchers and aortic clinicians. They collect the information from patients like you. That information is fed into a registry systems in Paris and in Houston, and then the scientists pull the information out to be able to compare the disease features and outcomes from different parts of the world in order to create a standards for the diagnostic standards and patient care. Well, we will move on now to hear a presentation for Dr. Maumenee, but let's first say a few words about Dr. Maumenee. And, you know, this is just a few lines from her very, very long CV. So we are honored to have Dr. Maumenee with us tonight. She is world-renowned ophthalmologist, and she will address the eye concerns presented by those with Marfan Syndrome and other genetic aortic disorders, and best treatment options where available. Dr. Maumenee has a lifelong interest in genetic eye disease. She is a faculty in the Department of Ophthalmology at Columbia University Medical Center in New York City. Prior to Columbia, Dr. Maumenee served in the Department of Medical Genetics at Johns Hopkins University for 40 years. The department was founded by Dr. Victor McCusick, which I'm sure many of you have heard, who had a very strong interest in disorders of connective tissue, including the Marfan syndrome. As a matter of fact, I think that Hopkins and the Dr. McCusick group is actually a cradle of Marfan syndrome science and what is now genetic aortic disease. Dr. Maumenee has a tremendous experience in genetic disease and is still pursuing her studies in medical genetics at Columbia University, where she's also working and establishing ophthalmology genetics department. We are very lucky at GADA to have worked with Dr. Maumenee for over 30 years. She is a member of our professional advisory board, and she's also a member of Multi-China Aortic Consortium that we call MAC. So in addition to Dr. Maumenee, we are very pleased to have a last moment panelist, Dr. Alia Abdelhakim, MD, PhD. Dr. Abdelhakim has, this is a long list, PhD in biochemistry from MIT, research work at Harvard, medical degree from Columbia University, residency in ophthalmology, and fellowship in surgical retina, both at Columbia, residence in medical genetics and genomics at Columbia University at present, and she holds faculty appointment in the Department of Ophthalmology there. Dr. Abdelhakim is working towards being double board certified in medical genetics and genomics. Her interests are also in inherited eye disease, systemic diseases with ocular involvement, and gene therapy. So Dr. Abdelhakim and Dr. Maumenee, welcome. We are extremely pleased and excited to have you here this evening. And now I will hand this webinar over to Dr. Maumenee. And Dr. Hakim, if there is a need to help out.
Hello, it is certainly my pleasure to be here today and to have been invited by GADA for this occasion. Please, if there is any problem with the sound and you don't hear me well, complain now, not in 10 minutes. so that we can move forward to everybody's satisfaction. My thanks go to Joe Pasca, who's president of GADA, and also her staff who have been organizing this event and for inviting me. I'm impressed with the large number of participants. I have no conflict of interest to report. What I'm going to do today is really spend most of my time on the Marfan Syndrome and the eye findings in the Marfan Syndrome. But before going there, I will talk about the normal eye to give you the anatomy and the function. I will then talk about the diagnostic findings of the Marfan Syndrome in the human eye and about management. I will if Dr. Abdelhagim wants to interrupt me, she's just very welcome, so that we see different sides of management for this disease. But here is a normal front of an eye. And you can already make the diagnosis of the Marfan Syndrome by just looking at the eye from the front as you see it here. What happens in the Marfan Syndrome? The pupil will be small, the diameter of the eye will be enlarged, and the iris stroma, which is brown here in this eye, will be much more homogeneous than in an eye of a non-affected person. If I go back, you will see all kinds of structures in the iris, crypts and surface structures, which in the Marfan Syndrome really disappear. The pupil in the Marfan Syndrome dilates poorly. And so it is one of the features you see, a myotic pupil, a pupil that is constricted. But what you also see is actually an eye that is deep set. So the retrobulbar fat is missing, just like the subcutaneous fat in the rest of the body. You don't appreciate that in this view because, you obviously need to see the full face in order to appreciate that the eye is deep set. Nor is it fair to compare the normal lenses. The magnifications aren't equal, but you get the idea. Here is a cut through the eye. What we saw as cornea in the previous picture, which is the front transparent part, is seen now in cross-section here. And behind it, you will see the pupil, in this case blue, in the iris, in this case blue, or here a greenish color. And you see behind it the lens. And the lens is then suspended by the zonules, the ligament, which holds the lens in place. It's fine structures like hairs that actually hold the lens in place and interact with accommodation. And we'll get back to the slide in just a minute. Behind, the front of the eye, the clear cornea, the multicolored iris in this case, the lens, which in this case seems somewhat cataractous, the zonules, you actually see the retina, which is this reddish appearance structure, which has blood vessels which supply it, and also has the macular area, which is the area of sharp vision. And what we can conclude from here is that if you look at something in the distance, that object, and the light that emanates from that object has to be focused onto the macular area, the area of sharpest vision in your retina, and also the surrounding retina. How does the eye do this? Well, let's look at a few numbers. We actually, if you look and think of an object in the distance of infinity, the rays will be parallel, the light rays, and they will hit first the cornea, which has a strong power that it can focus the light beam on the retina. It almost gets there. It doesn't do the fine tuning. And the fine tuning happens with the lens. And as we get older, our lens doesn't fine tune that easily anymore, and we need glasses in order to get this done. But what happens in the Marfan patients, where this power of the cornea basically gets a parallel light into focus on the retina, in the Marfan syndrome, it will actually move the image behind the eye, because cornea in Marfan patients is much flatter than normal. And this is actually inducing hyperopia, farsightedness. But I didn't think I forwarded that. Okay. But the lens behind it has a power to focus the eye, you know, as I said earlier. But what happens in the Marfan eye is the lens, the distance from the front of the eye to the retina is much enlarged. And so that's where the myopia comes from. The image will focus in front of the retina. So you have a complex issue of the front of the eye leading to farsightedness and the length of the eye leading to nearsightedness. And the lens in Marfan patients, when there is lens dislocation or when there is breaking of the zonules, will round off and be actually more myopic and lead to more myopia. So you have two factors leading to myopia and one factor leading to farsightedness. They may compensate for each other a little bit, certainly in the early years. And so patients with the Marfan syndrome usually don't come to attention until they are 5 or 6, when they may sit on top of the TV and the family gets annoyed by the fact that they obstruct the view, and the family takes the patient to the pediatrician, and the pediatrician says you ought to go to an eye doctor. So usually, or in many cases, the first diagnosis of the Marfan syndrome gets made by the ophthalmologist. And that's a fairly 30–40% and more of the patients get first diagnosed by an ophthalmologist. And you can there see why Marfan Foundation, as well as GADA, thinks that the eye findings are very significant for the diagnosis. So what happens with this sort of abnormal collaboration of these different structures is you have the high refractive errors, which result in high myopia, but also have a flattened corneal curvature. You have the lens dislocation and increased axial length. Now what happens is that this doesn't happen in a symmetric fashion in the eyes. You therefore may be more nearsighted in one eye than in the other, and the patient may develop amblyopia or a lazy eye. And we see that sort of develop in the first 10 years of life, but it's usually quite easily reversed because typically at birth, none of these features are present, so that there is early healthy visual development between the eye and the brain. Occasionally, patients may show strabismus. And strabismus, that means the eye is cross-eyed or turned out. And in the Marfan patients, it's typically turned out. And that happens in, let's say, 10% of patients. But once you get the refractive error, the myopia, the astigmatism that happens in these eyes corrected, this problem of amblyopia will typically disappear because I have operated on very few patients for strabismus in the Marfan syndrome. You know, a handful or less than 10 out of 2,000 some patients. What happens in addition to the high myopia is astigmatism. Sort of the cornea gets distorted, not in a perfectly round fashion, but also in an induced angle. So that there is one direction the cornea may be flatter than in the other, which leads to astigmatism. The lens may lead to astigmatism. So the refraction, the all-over refraction in Marfan patients is really quite complex. And you can spend a lot of your time, and Marfan patients and Marfan children especially should have attention to correction of their refractive errors. And there are many patients who go through life with just changes in glasses and never need surgery. These refractive errors are not what blinds the Marfan patients if handled correctly. What blinds them is glaucoma, other retinal detachments, and are cataracts. The glaucoma is seen in at least 30% of patients and may be seen as early as shortly after birth, but that is unusual. More commonly, it occurs in the 30s, 40s, at a younger age than what it normally happens in the non-Marfan, non-connective population, where glaucoma occurs in the 60s or 70s or 80s. Retinal detachments may be seen early, but it's really unusual to see it in the first decade. Sometimes in the second, more commonly in the third, and so on. And I have seen retinal detachments occur as late as patients in their 70s. Cataracts, again, occur at a younger age than in the normal population. Cataracts in the normal population occur, let's say, around age 70, 80, 90. And the common line is that everybody gets a cataract in their lifetime if they live long enough. I'm not sure that's true and is correct, but that's what all ophthalmologists learn when they go through their training. But Marfan patients, it will happen 20 years younger than in patients who don't have the Marfan syndrome. Why do we get all these complications? Let's look a little bit at the histology and what is going on. But before doing that, I want to shortly point out the clinical features, which involves skeleton and the cardiovascular system. And I'm sure GADA will talk more to you about this as time goes by. We can also divide the Marfan syndrome into a neonatal form or neonatal Marfan syndrome, into the classic form, let's say, where onset seen by an ophthalmologist maybe less than 10 years, 5, 6, often in teenage years, and there may be a delayed onset, and you may recognize features of the Marfan syndrome in a patient who has onset in their teens or diagnosed at the teens, and you look at the parents and you say, oh, this patient has the Marfan syndrome. Microspherophakia is seen in the neonatal form. This disease is seen at birth. And it's a difficult diagnosis because basically physicians don't recognize it. There is neuromuscular disease and all kinds of tests get done to rule that out. And really it's an eye examination which often leads to the correct diagnosis. Patients will not have typical lens dislocation, which we'll see pictures of in a little bit, but actually have microspherophakia. During intrauterine development, the lens doesn't grow normally, and it's actually much smaller, and it's actually round. It looks like a round bead. Rarely these patients have infantile glaucoma, or glaucoma actually sometimes seen right at birth. and they may get retinal detachments again prior to age 10 years. But this, neonatal form, I would think is maybe 5% or 10% of the Marfan population. The classic form, we see progressive lens dislocation. Marfan syndrome is a progressive disease. Basically, everything appears normal at birth, and the pediatrician just releases them, and then it becomes kind of obvious that the patient is getting taller than the siblings and the parents, and that the child is just on the tall side, and the eye findings may come. And so the patients will get sent for an ocular evaluation. As I said, and ophthalmologists may see a refractive error. Oops, sorry for that. May see a refractive error as we described. The patient is nearsighted, but they may not recognize the lens dislocation right at the beginning, because you have to dilate the pupil well to look out to the periphery. As we said earlier, the pupil doesn't dilate right. So it's just, and children don't like to get drops into their eyes. So that even though there may be mild dislocation, the ophthalmologist may not recognize it. If you have experience with that, you can see that and get that done. But that again takes an ophthalmologist who has experience with the Marfan syndrome. Retinal detachment may be seen again at various ages, and then open-angle glaucoma, again, maybe in the 30s, 40s, 50s. And there are patients who have a delayed onset. I have seen lens dislocation occur in patients in their 70s. And this was a patient diagnosed by Dr. McCusick, whose name you earlier heard. She had bilateral lens dislocation in her 70s, in the two eyes, a few eyes apart, with very rapid total lens dislocation. Those cases are unusual, but they are seen. I've seen patients with delayed onset who had as primary feature a retinal detachment in their 70s. Again, pre-senile cataracts in their 50s, in their 60s may be seen. So these are all features that fall out of the ordinary of what you may know for the Marfan syndrome. But how does all of this develop? Basically, fibrillin, which is the gene or the protein, which the gene of which is mutated, is distributed through all the structures of the eye. It is not in the vitreous gel, which is the gel that fills the inside of the eye. That gel is abnormal in patients with testicular syndrome. And you may have heard that name and that diagnosis for the differential diagnosis. It's in the endothelium of Schlemm's canal. It's in the lamina cribrosa, which are all structures which are relevant for the development of glaucoma. Ciliary body is fibrillin. It's in the fibers that lead that connects the ciliary body to the lens capsule, as we see here. And we see here a picture of the lens capsule from a normal eye. And what we see here are zonules, or these fibers that go from the ciliary body to the eye and suspend the eye. And they're in bundles inserting here on the surface. They're not obviously inserting as you go further towards the center of the lens capsule. And here we see zonules stained with the antifibrillin antibody, which was given to us by Dr. Lynn Sakai, who has been one of the prime investigators of the biochemistry of the Marfan syndrome. She's in Portland, Oregon, and still involved in the Marfan Foundation. And here we see this brown color all over the lens capsule, cut in a different fashion. And you see how these fibers are inserted here in bundles going into the lens capsule. Here more views at higher magnification. And the amazing thing is that these bundles may take on these dumbbell configurations, and we think this may have something to do with the accommodation of the lens as seen in a normal eye. They may have different structures seen here in a larger sort of constellation, and again here in a lens capsule where they insert in bundles and sort of in a striated fashion. And here when we look at a drawing from what we imagine is a picture, we see them here in the these zonules or lens of these fibers, zonular fibers as they are drawn on the surface of the lens capsule. And we see them here in a patient. And we see here her lens, which is crystal clear. I think she was about 10 at the time. And we also see sort of a funny, sort of irregular shape to the edge of the lens. We see these zonules that connect here in an irregular fashion. Here they are broken, here they are broken. And so it creates this picture. And we see other pictures where the edge of the lens is totally clear, is totally round and totally normal, but the lens altogether is dislocated upwards, a direction that is commonly seen when the lens first dislocates. And we see here again that the iris is sort of amorphous and doesn't have the crypts and folds that are seen in a normal iris. And here another eye where the edge of the lens may be sort of intuitively seen, will be right there, and the lens is dislocated, but certainly there is no major lens dislocation. Again, sort of a similar structure. And here sideways again with the crenulated edge. And here's a patient with the Marfan Syndrome who also has a cataract in his lens and who has a clear axis. This patient obviously dilates beautifully, but you have a clear axis from the front of the eye to the back. And a patient like that, you can actually give them glasses through this clear part. You don't need to look through the lens to see the back of the eye. We learned earlier that the lens helps with the fine focusing, but you can give a patient bifocals to help them get the fine tuning done, or you can give them contact lenses and the bifocal glasses over it, or aphakic lenses, and all of that may be well tolerated. And here again, a denser cataract, again, some of the zonules which hold the lens in place. And here, a really dense cataract. This patient is not looking through his cataract. He is using his vision around the lens. He's using this space. He died in his 70s from cancer. He never had his lenses removed. And whenever he came to see me, people said, why don't you take that lens out? And the patient would look at me, he said, I don't need that lens. I look around it. I just am fine. Leave that lens in. I see just fine. So not all patients with the Marfan syndrome need a lens removal. And I would like for you to take that definitely out of that message out of today's presentation, that you can just give glasses around the lens and patients may be fine. In some patients, this lens will dislocate all the way into the vitreous. It will disappear behind the pupil and you have a clear space without lens, and it's tolerated in that space for some 20 years and doesn't give people any trouble. What we see here is actually again the retina. And here in a patient with the Marfan syndrome, where we see a very elongated globe, the eye altogether measured over 30 millimeters. Normal is 24 to 25 millimeters. The longest I have seen was 34 millimeters. So the eye in the Marfan syndrome may be very long, just like the bones. So the eye is just bigger than normal. Why it grows to the excessive size is unknown. Does it stretch under the normal pressure? The sclera that is full with fibrillin does stretch unusually, but not all Marfan patients will have a very long globe, but some do. But this may be just a significant feature, and the retinal detachments, as they occur, are more likely to occur in patients who have a very long globe. As we see here in the diagnostic criteria for Ghent 2, aneurysm or dissection of the aorta and ectopia lentis are the two cardinal findings, diagnostic findings and criteria for the Marfan syndrome. That's why eye examinations in Marfan patients or patients suspected of having the Marfan syndrome are very critical in their management. Well, here's a long list, and I know you can't read it. But here at the top is fibrillin 1 as the gene that gives the Marfan syndrome when mutated. Still today, about 80% of patients who have a dissection of the aorta have mutation in fibrillin 1. And it goes to TGF-beta receptor 1 and 2, MYLK ACTA2, which is a significant one, also are the Lois-Dietz genes, TGF-beta 3, and it goes on and on and on. And you know, I have seen several of the SMAD genes, and the overall estimate at present is that there will be 60 genes which will predispose you to the development of an aortic dissection. I have not seen patients with all these entities, and many have not been carefully evaluated. The most common cause for lens dislocation is not the Marfan syndrome, but is trauma. But in case of trauma, it's usually unilateral, but you just see it iatrogenic at the time of surgery, persistent hyperplastic vitreous, syphilis. But then there are isolated ocular involvement. There is simple ectopia lentis, which is actually in most of the cases caused by mild mutations in fibrillin 1. There's an entity called ectopia lentis et pupillae, which is an autosomal recessive disease and gets typically misdiagnosed. It gets missed. Patients don't, ophthalmologists don't know it. It affects 1 in 50,000, 1 in 100,000. So it's a rare disease and falls under the rare diseases. And it just doesn't have systemic diseases. You don't have a dissection of the aorta, certainly not in patients into their 20s or 30s. You see lens dislocation in aniridia, megaloponia, which is an X-linked condition in most of the patients. You can see it in congenital glaucoma. You can see it in colobomatous malformations of the eye. But basically, these conditions do not have aortic disease, nor do patients with autosomal dominant isolated ectopia lentis. This was a patient seen by Dr. McCusick, and I then inherited that whole family, and nobody had a dissection of the aorta. This patient in her 60s developed scoliosis. They all had ectopia lentis, and they mapped to the fibrillin locus At the time, we did not sequence the whole gene. You see patients who have these small filaments and flocculi, as it's called, sort of like little clouds in the pupillae axis. And these are patients with mutations in ACTA2. And when an ophthalmologist sees that, they ought to recognize it, but they obviously often don't because it's just considered benign and let go. But it's this little flocculi are also seen in ectopia lentis at pupillae, which you see here where the pupil is dislocated. And here you see one of those flocculi. And you can see that the pupil is dislocated to below. This is obviously cut off and not a very good picture. These patients show dislocation of the lens, pupillary block. And in the past, people would be afraid that patients with the Marfan syndrome will develop a pupillary block. I've seen it twice in 2,000 patients. People would be given drops to prevent this. It just isn't a feature of the Marfan syndrome. But what you can do when you see a patient whose lens, here you see the edge of the lens, when you see them and the pressure will be 50, you dilate the pupil, you push on the eye and the lens will fall back. You let them lie on their back. You constrict the pupil and the patient will be back okay. You schedule a lens removal because these lenses have to come out. So here's systemic disease, and there is a long list where you get also lens dislocation. But patients in this list do not have aortic disease except for the Weill-Marchesani syndrome, which can be caused by mutations in fibrillin. But they're also, most commonly, this is a recessive disease. So what I would like for you to take out of this, Marfan syndrome is a progressive disease. We know very little about the eye findings in elderly Marfan patients. And I hope that with the help of the Marfan Foundation, and certainly with the help of GADA, we can put that information together. The Marfan syndrome is a complex disease, and the management of the eye needs very specialized care. And certainly, I think more centers specialized towards development of the eye, towards treatment, development of a service which focuses on the eye will happen at Columbia and will happen in other institutions so that patients get the maximal and the best treatment they can hope for. Lens surgery is a complicated issue, and again, it should only be in the hands of experienced surgeons, and there are some in every major center in the US and I'm sure abroad. The glaucoma in the Marfan syndrome is actually usually pretty easy to handle. If the lens is in the vitreous cavity, the lens ought to come out. A lens in the Marfan syndrome is leaky because of the lens capsule, which is full of fibrillin, and lens content may leak into the eye and lead to inflammation and glaucoma. So, but when a lens is in the vitreous, 20 years in there is okay. If a patient has a Marfan syndrome, take the lens out first, and it may all come back to normal, to the normal status. And then we have here the retinal detachment, and we may, if you have questions about it, we can send them to Dr. Abdelhakim, who is a retinal surgeon and has experience, certainly with management of the retinal detachment in complex patients. But the sooner you diagnose it, the better. You may just get away with just laser surgery around the hole in the retina. And nobody has ever come up with a very specific mechanism, which is typical for the Marfan syndrome, and how you may recognize it early, that I know of, and what the steps are. But when the patient becomes symptomatic, and we may ask Dr. Abdelhakim what the symptoms are, what you should do. What I also want you to get out of this, that all patients who have an aortic dissection and or a dislocated lens, if there hasn't been trauma, ought to be evaluated for the cause of it by having a DNA analysis. It is available now, and all of your DNA, which can be taken from a small venipuncture or taken from a sputum sample, will further the research into aortic dissections and ocular complications. Little is known about the ocular complications of all the subtypes of aortic dissections. But GADA, I'm sure, will continue to contribute to the needed research and patient education of lens dislocation or of aortic diseases. And we at Columbia are going to continue to work on this, to work on the subtypes, to move this forward. And I thank everybody for having been listening to this, and we are ready to answer your questions. You have sent us questions over the internet, and I'm sure Ms. Pasca will take on the obligation of handling this as we move forward. At present, Dr. Abdelhakim is seeing patients on Fridays at Columbia. I have to give a shout out here, and I'm sure she would be happy to see you. I'm not seeing patients anymore, and I'm certainly not doing surgery. I'm evaluating records and try to put the research data together that we have accumulated over the years. And there we go. And I turn this over to Krizan or Josipa for the next step.
Okay, can you hear me? I've been told I'm muted. Thank you, Dr. Maumenee. This is great. I think everyone has noticed that the presentation was really mostly about Marfan syndrome. And there comes the very reason, one of the many reasons why we have organized this webinar. We, in fact, would like to know more about the eye involvement in other genetic disorders. But we cannot do that without you. GADA is, I mentioned earlier, there hasn't been any research on the eye in aortic diseases in many, many years, and definitely not much or almost none in the other, in the multitude of other genetic aortic disorders. So GADA is determined to remedy and change that, but we do not, we cannot do it alone. We need your help because you know how you feel, you know what your symptoms are. So, you know, there is a perplexing question that we ask ourselves all the time, and that is, number one, what is the state of the eye health in aging Marfan patients? So if you look at, if you realize that most of the research was going on up until 20 years ago, there is now 20 years of history that is unknown to us. So we have some examples mentioned by Dr. Maumenee about patients, you know, manifestations at later age, but generally we do not know that about Marfan patients, and we don't know much at all about the other patients with other diseases. So as mentioned by Dr. Maumenee, no institution so far, Marfan Foundation hasn't done the research and follow up on their patients to see what their aging process looks like. And it's not just in the reference to eye, but it's also referring to many other aspects of the disease. So we will, hopefully you will hear from us, as we are planning a large research project that will uncover and unearth more about the state of the health of patients with aortic disease. And that's just not by the aorta, but about their neurological situation, about the mental health, about the spine and skeleton, and many other aspects of it. So with that in mind, I would like to call on a couple of groups of patients. We were not able to answer your question because we did not have enough information. So I call on to those from California, Greece, and British Columbia who wrote relating to ACTA 2. With your permission, we will email you to ask for more information, and with the purpose of us learning from you, and hopefully us being able to deliver some answers to your questions later on. We also, I also called to Manitoba to a patient with EDS and MYH11 mutation. These are two very different diagnoses. So we will need a little more information to know exactly what your concerns are and how to respond to them. We also call to those from South Carolina, North Carolina, Texas, in Australia, who have aortic and eye features, but have no diagnosis. So you wonder if the two are connected and how. So we urge you and many others in the audience probably to have a full aorta panel genetic test done. So not just the traditionally, they will test for fibrillin 1 and Marfan syndrome. They will test for the spectrum of Lowen's-Dietz syndromes and Ehlers-Danlos, but they will not be looking for other mutations like ACTA2 and MYH11 or PRK and so on. So please ask for full aorta panel aortic test. That will give you the best indication as to what to expect in terms of your future health issues and how does that relate to your eyes. And I will move to the actual questions. I will start with a family from Northern Ontario, where multiple members have the same EDS, collagen 4A1 diagnosis. And the questions, the statement is, myself, my daughter, my son, and my mother have all been diagnosed with collagen 4A1 partial gene deletion. We all have eye issues. My mother has cataract surgery and has developed a wrinkle in her retina, and leaving her with limited vision in one eye. Son has keratoconus, which is probably something that Dr. Maumenee wants to address. And I have damage to my optic nerve, but pressure is good, so I'm not sure if I have glaucoma. So we are wondering if this is all related to collagen 4A1 gene mutation, thoracic aortic aneurysm, and bicuspid aortic valve. Well, certainly the last two ones, the thoracic aortic aneurysm and bicuspid valve, and most probably related to the collagen 4A1 mutation. But maybe Dr. Maumenee can tell us a little more.
Yes, delighted to tell you more about that. I must say, you know, whenever a patient with some Marfan syndrome is seen, ophthalmologists wonder whether they have keratoconus. They just don't. So you see a cone, an anterior cone. They may have malformation of the inside of the cornea, but certainly not the standard cone. So the patient with collagen 4A1 is one of these rare patients who have a keratoconus. Keratoconus, I know it exists in a marfanoid habitus with keratoconus, without aortic dissection. I've seen patients like that, and that was before DNA analysis. And I'm sure there is a sub-entity out there that hasn't been identified on the molecular level. But collagen 4A1 is a small blood vessel disease, and you find vascular anomalies in the brain and vascular anomalies in the retina. And certainly you need to get under the care, and I'm sure you are, of expert clinicians and surgeons to handle your problem. We would be delighted to work with your ophthalmologist if you want to, and trying to work this out what's going on in the eye, because we would like to get that into the literature and work with your ophthalmologist to get this done. Because I'm not aware of this having been published in any detail, and I haven't seen it in the ophthalmic literature to the point that it deserves. So this is clearly one of these sub-entities of aortic dissections which need further eye work and publication.
I have another question that came from the audience now. Thanks for a great talk. I'm wondering whether the flocculate you described in ectopia lentis are similar to the deposits seen at pseudofoliation syndrome, which are rich in fibrillin 1.
Yeah, they're not. They look very different, and these the flocculi actually seem to be ruptures of cysts, whereas pseudo-exfoliation is actually caused by deposits. So it's a different mechanism. You get sort of white flake-like material, but the patients who have pseudo-exfoliation are at high risk of developing a lens dislocation at the time of surgery, and are likely to have a complication of rupture of the lens capsule during surgery. So they are complicated cases, which you must already know from your ophthalmologist, because he pointed this out to you, and patients get a cataract at a younger age. So I think you're probably in good hands with that. But they are separate conditions with overlapping symptomatology. And people have wondered about, the exact relationship and how the pathways meet for quite a while.
Okay, another question from the audience. How do I raise this with my I'm not sure if this is ophthalmologist.
Probably.
A mutated FBN1 gene and extreme family history of aortic aneurysm. I'm having some double vision problems, shadows when I read, and I have been through extensive testing with my NO. There was no discussion about Marfan's during my multiple visits. So what do I say to encourage them to explore Marfan connection to vision issues?
I would think so. It's, I think much of the care of patients, eye care of patients with the Marfan syndrome, is actually sort of problems with refraction and getting the refraction right, and get the glasses right and contact lenses and manage the problems that are there. But, somebody ought to be able to do that. But certainly the Marfan syndrome ought to be considered in your case, and somebody ought to do the work. Alia, anything?
No, I completely agree. I just, it sounds like maybe there's more of a workup that's warranted in this situation, and I'm curious if maybe having another specialist on board wouldn't be useful, either somebody to do a more careful refraction or to take a look at the lens more carefully as well as the retina in this situation.
Okay, from Calgary, Alberta, a patient with LDS5 or TGFB3 mutation. Is there a connection to visual snow, shuttered flickering of light and shadow, flashes of light and starbursts? Is there any treatment for it?
You want to answer that? So that's one of the Lois-Dietz variants.
Yes.
Yeah, Alia, I leave it to you. What flashes of light?
We hear that often from Marfan patients as well.
I don't know what they mean by visual snow. If it means flashes of light, then certainly that could be a retinal issue. But visual snow, I think, refers to something maybe slightly different. And I'm not sure if visual snow in particular and Lois-Dietz syndrome are related. I haven't seen enough Lois-Dietz patients, Dr. Maumenee.
Yeah.
Have you seen that sort of connection?
No, sorry to put you on right there, but I think it's generic to the Marfan patient. I think the patient may just have a vitreous detachment and may have vitreous symptomatology, and I don't think there's anything, but I ought to see a retinal specialist and make sure there isn't a threatening retinal detachment. How does that sound? I asked Alia, what do you think?
What was that?
I don't know.
What's that?
Do you have any other points? I thought she may have a posterior vitreous detachment.
That could be. No, for sure that could be. It just depends, like, what they mean by visual snow. Because, like, if it's like a vitreous detachment, you know, it's a very typically, it's like it lasts for like not, you know, split second. Usually noticed at night. You know, kind of like these kind of like lights, like kind of lightning in succession. That's kind of like very typically the vitreous separation symptoms that you see. And what they mean by visual snow, I'm not sure if that's referring to the same thing. So it really depends what they mean by visual snow. Yeah, could certainly be a vitreous separation though.
So there is a comment here, visual snow is like static over the entire visual field and all the time.
Is it over both eyes at the same time?
Yes, both eyes.
Okay, that may just be an ocular migraine.
Yeah, so the visual snow, when you say it's like static over the entire, do you mean like floaters? Or is that, does it move? It's a little, again, it really depends on what floaters as well. Oh, they're separate. Okay. I mean, certainly if you have vitreous syneresis and there's changes to the vitreous and, like, you know, in these conditions, you know, the vitreous can be different from in patients who don't have these conditions. You may certainly be seeing these changes in the vitreous, you know, as they cast shadows on the eyes. And that's also, it could be connected, but people without the syndromes also see all sorts of artifacts from having vitreous syneresis, as well as, like, you know, changes to the vitreous as the patient gets older. So it can be, but I would say it warrants, you know, a further evaluation with a retina specialist to really kind of rule out retinal and vitreous contributions to what you're seeing.
Okay, we're gonna go on to Houston. Lois-Dietz 4 diagnosis or TGFB2 mutation. And the question is, at times my right eye seemingly trembles in the sequence with my pulse. So the patient thinks that maybe that is exacerbated by coffee, or is it fatigue? Do you have any suggestions?
It sounds like a myokymia, and people get that with fatigue, and it doesn't really matter, but you know, it goes away, so I wouldn't worry too much about this.
Dr. Maumenee and Dr. Abdel Hakim, can you tell us a little bit more about the ocular migraines? They seem to take place in all kinds of shapes and forms. They are definitely reported by many different patients, and I think also general population. So any insight on it would be really helpful.
I'm happy to take it unless you take it. I'd be happy to turn this to you.
Yeah, ocular migraines are very interesting. I don't know if there's any connection necessarily between ocular migraines and, aortic syndromes with aortic dissections and in particular, but ocular migraines, they're kind of, a subtype of migraines. They can be associated with the typical headaches, migraines that people experience either preceding a typical migraine or not associated with a migraine at all. And generally speaking, people kind of experience that what they say is kind of like a kaleidoscope. Mm-hmm. That's a very, very typical description of the ocular migraine. They see these kind of triangles or kind of colorful phenomena in the kind of in the periphery of their vision. And usually these last for about, I would say 15 to 20 minutes is a typical ocular migraine, and how much and in how long it lasts. So if it's something that's lasting just a few seconds, it's unlikely to be an ocular migraine. If it's lasting 2 minutes, it's unlikely to be an ocular migraine. And honestly, ocular migraine can present as anything. Typically, it's the kaleidoscope and the funny colors in the periphery, but it can be blurred vision. I've heard people say that it's more like a blackout in their vision. There's a wide variety of way ocular migraine can present. And, there's a lot of theories in neurology as to why the migraine occurs. They're usually kind of followed or managed by neurologists and neuro-ophthalmologists. But that's typically how they describe it. A lot of the time they come to retina specialists because they're I'm seeing flashes in my vision. It's not actually a flash, and when you probe a little bit further, you see that, they're very different phenomena. The flash is really just a split second, usually at night, usually with eye movements. A migraine kind of strikes, and it's usually there, it's kind of this visual phenomena for 15 to 20 minutes and then goes away. It can be in one or both eyes. So it just needs a little bit more probing with the symptoms in that regard. They're usually benign and harmless. It's just people kind of they're taken a little bit aback when they experience it, especially for the first time.
I think they come with fatigue. I think fatigue has a lot to do with it. And I think when patients, I used to hear a lot of patients complain when they had aortic surgery, that they had these migraine phenomena. They never knew whether they saw clots being in the immediate post-operative period, or whether this was fatigue. Nobody gets enough sleep in an intensive care unit. And so it could be both, but they usually go away and don't really matter. You may want to cover one eye and then the other and see whether it's in both eyes. Then you definitely know it's in the brain, and there's nothing to do with the eye as such, even though it's called ocular migraine.
Thank you, both of you. Okay, I will just change. We have two series of questions that's related to lens dislocation and how to remedy that. But first, a question from Australia. I have a history of ruptured ascending aortic aneurysm at 19, but still don't have a diagnosis. My daughter, who is also undiagnosed, has vitreous veils shown in last eye appointment. How often would you recommend dilated eye exams? So this could be Stickler syndrome.
And the question is, what are those vitreous veils? Marfan syndrome patients don't get vitreous veils. And you probably, if you had a DNA diagnosis, you had sequencing of the fibrillin. So it could be one of the vascular anomalies that actually led to this, the collagen 4A1 or maybe even ACTA2 or something else than a typical fibrillin mutation. So you probably need more extensive DNA analysis to come down with, to figure this out. But you need to figure this out, whether this is actually blood that you get the vitreous veils or whether it's in the vitreous. The vitreous in the Marfan syndrome is most classically just normal. It just isn't a problem. So I don't know what the cause was. And, you know, if you want to send us a medical record, we'll probably look over it or send it to Mrs. Pasca and go from there. You know, somebody can look at it. You can scratch out the names and we can look at it.
Yeah, certainly a genetic test would probably be very useful as well.
Yeah.
So another question, a question from Canada. It talks about migraines, which we just talked about, but also, could epiretinal membrane be related to Marfan syndrome? No?
I can take that one. Epiretinal membrane can be related to a lot of things. I don't know if like the incidence of epiretinal membrane in Marfan syndrome is necessarily increased, but epiretinal membranes can form when you get something called a posterior vitreous detachment, which probably occurs at a younger age in Marfan patients. The posterior vitreous detachment just basically means the jelly in the eye peels off of the retina. And because Marfan patients have longer eyes, posterior vitreous detachments tend to occur earlier, and that's why also Marfan patients tend to have a higher rate of retinal detachments and that sort of thing, is because the interface between the vitreous and the retina is a little different from people who don't have Marfan syndrome. So with the entire incidence of like vitreous separation from the retina, there is likely a higher likelihood of epiretinal membrane forming. And what epiretinal membrane is, it's just basically, you know, specific special kinds of like kind of like almost like scar cells that are like growing on top of the retina and causing it to wrinkle a little bit. So you kind of see, you know, a straight line that you would normally see would look crooked in like more severe cases. So, you know, whether epiretinal membrane is like occurs in Marfan patients in the absence of a posterior vitreous detachment, not exactly sure that is the case, but I'm, you know, with the increased rates of posterior vitreous detachments at a younger age, I wouldn't be surprised if that is the case.
Thank you. From United Kingdom, I have Marfan, age 42, and my daughter, age 3, has inherited it also. Concerning my daughter, whose lenses have dislocated, so she's 3, her lenses are dislocated, I'm interested in thoughts on the best age to remove the lenses.
I'd be happy to take that. You know, your number one obligation should be to give the child the best optics that correct the aberrations that come from a dislocated lens. And you can do that. Your ophthalmologist can do that. And a patient by age 4 or 5 ought to see 20/20 or 1.0, whichever measurements you use or your ophthalmologist uses. So she belongs into the care of a good ophthalmology department where they work on her refraction. And there's absolutely no reason to take the lens out at this age. You can just continue, you know, working with the refraction, and the child ought to have 20/20 vision in both eyes at the latest. If you diagnose at age 3, at the latest at age 5 or 6. You know, that's when other children reach the vision of 20/20. And with staying on top of it, you ought to be able to get there. We always got there, always promised it to patients, because all that it is that happens at those early stages is that the lens rounds off and that the patient is more myopic and that you develop astigmatism. But if you take the lens out, you make the optics much more complicated. And to suture an implant or to fully correct the visual status of an eye, once you take the lens out, you need to suture an implant in. You need to give a contact lens, you need to give glasses, contact lens, or suture an implant in. The implants that are sutured in give you the best correction, but there really isn't the perfect lens at present. So it's still a distinct issue because the suture material that has been used tends to rupture. People use stronger suture material now. People have threaded the haptics, which is the loops that are on those lenses, have threaded them into the sclera. And I think a lot of them will erode through. That is done primarily in India, but there are different people who are using that approach. And people put lenses into the anterior chamber. And I have seen patients with a lens in the anterior chamber that is in front of the iris who have shown severe inflammation of the eyes. And I've taken those lenses out, and I think it's just the wrong approach. So if you can keep a patient with 20/20 vision and you want to treat them that way the longest possible. So there comes a point when they don't like their glasses anymore, when you switch them into contacts, and you can handle that for quite a while. Most patients get used to it and do all right. But ultimately, many people want refractive surgery. So you just have to somehow figure out what's the optically best approach for a given patient. And that has to be seriously discussed. But, you can just delay this. You don't want to do any surgery under the eye is fully grown, and you can just put in an implant that's appropriate for the rest of the patient's life. So, don't rush into it. Just hang in there and work with it and work with an ophthalmologist. Make sure that the patient doesn't get trauma to the eye, and just nurse it along, and everything may be all right. Especially diagnosed early, just do it.
Very quickly, thank you. Very quickly, another question related to that from Stockholm and Marfan Syndrome patient. Last year, I had the lens replaced in one eye. The focus is close up from 15 to 50 centimeters only. Everything around and the distance is blurry. Is this how it was supposed to be, or is it something wrong?
There's nothing wrong with that. And, your surgeon should have or has probably tried to discuss that with you, or somebody in his office, because you put the vision for a patient relatively close, because much of your day you spend with close vision. And if you take a lens out, or you finish up with extreme distance vision, which is also blurred for distance. If you do a cataract extraction in a patient, in an elderly patient, you try to put them into focus, that they see what's on their plate, that they can, when they first wake up, find their glasses, sort of that they have a refractive error, which gets them which gives them close vision or relatively close vision, which gets fine-tuned with glasses. So that should have been discussed. But if the vision, I'm sure the vision in the other eye will get worse. And if you don't tolerate the imbalance, then I think you may just want to have the other eye set at more or less the same distance, so that you can fuse the two eyes again and the image of the two eyes. But that needs to be carefully evaluated. There are some patients who like to have one eye for distance and one for near. And often, presidents, you never see them in glasses. They have one eye, they wear contacts, one for near, one for distance. And handle this. At least a lot of them do. I used to work close to Washington for decades, so you know, you would work on the refractions for people in power, and you never see them with glasses, but they used to just, you know, have one eye corrected for near and one for distance and would handle that. So, you know, it's different. It differs between patients. Some patients like to be in focus for both eyes at the same distance, but most patients want to have the focus set for an intermediate distance closer to close, because that's where your daily activities are, and then use glasses over it for distance. Alia, anything?
No, I think I agree with everything you just said there. Not sure I have much more to. Yeah.
Okay.
Yeah.
Well, I think that covers it for Stockholm. If any of you have any further questions or would like to receive some more further explanation relating to your case, we will be, with the permission of Dr. Maumenee and Dr. Abdelhakim, can we forward your contact information to the patients, to the audience, so that they can contact you when needed?
I like an email.
Okay, very good. So thank you both. I think we are coming to close to the end of our, I have no more questions, and we are at the end of our webinar. So I would like to now, I thank Dr. Maumenee and Dr. Abdelhakim one more time. And I would like to remind everyone to please fill out the survey after the webinar and send us your feedback in order to help us improve our service to our community. We expect that this is probably not going to be the last and only eye webinar, that as we gain some more knowledge and understanding, we will be expanding that. And I would like to remind you that the webinar has been recorded, so you will be able to see it on the GADA Canada YouTube channel. And for that, we will have links posted on social media, our website, and shared via email directly with you as soon as that is available. So GADA is committed to provide patients with needed information, so watch for upcoming webinars. Family planning. Oh, I'm missing the last page. So the upcoming webinars on family planning, quality of life approaches, addressing anxiety and depression as part of genetic aortic disease, and a specific session for those with ACTA2. There are many, many different mutations and variants in ACTA2, a disorder that I think it's important to know about, because you don't want to always hear about the features of the worst form and think that maybe this is something that is potentially happening to you. That will be followed then by webinars on other genetic disorders outside of the Marfan and Lower Seeds. I would like to bring your attention also to the publications that are coming out from the China Aortic Consortium, where we have a comparison of 11 results on comparison of 11 different genes. And it's fairly comprehensive. It will also, the information from that will be used by American Heart Association, American Association of Cardiology, to set up the standards of care and diagnostic criteria for all hereditary aortic disorders, or what we call genetic aortic disorders. So please check our website and our social media on the regular basis, and please get in touch with us whenever you need. Thank you very much for your attention. It was wonderful hosting you tonight, and we'll see you soon.